Good morning, guys. Today we are going to continue with our book club on the fundamentals of diagnostic radiology with the second part of the chapter on the diffuse lung disease. Dr. Ibrahim will present us from the inhalational diseases to the end of the chapter.
Good morning, Dr. Ahmed. Good morning, everyone. My subject is inhalational disease. First, pneumoconiosis. Pneumoconiosis is used to describe the non-nucleastic reaction of the lung to inhaled inorganic dust particle. The accumulation of these particles leads to two types of pathologic reaction that may be seen alone or in combination with the fibrosis, which may be focal and nodular or diffuse and reticular. Asbestosis is the generic term for a group of fibrous silicates that are resistant to heat and various chemical insults. Asbestos is divided into two major subgroups, the serpentine and amphiboles. The commonest one, and now it's used in USA, is chrysotile. This is the serpentine type, which is the safest one. The amphiboles, it's straight needle-like fibers, and it's not now used. Asbestos inhalation causes disease of first pleura, parenchyma, airway, and lymph nodes. The pleural disease may accumulate in the parietal pleura, cause pleural plaques, may cause pleural effusion, localized visceral pleural fibrosis may cause, or diffuse pleural fibrosis sometimes can cause mesothelioma. Pulmonary parenchymal manifestations either cause interstitial fibrosis, which is called asbestosis, round atelectasis, or bronchogenic carcinoma. The asbestosis is defined as diffuse parenchymal interstitial fibrosis caused by inhalation of asbestos fibers. The development of asbestos depends on both the length and severity of exposure. The clinical manifestations are usually not apparent for 20 to 40 years following the initial exposure. The characteristic structure consists of core transparent asbestos fiber surrounded by a coat of iron and protein. Asbestos bodies are usually found within the interstitial fibrous tissue or air space and only rarely in the pleural plaques. The number of asbestos bodies and fibers per gram of digested lung tissue is roughly proportional to the degree of occupational exposure and severity of interstitial fibrosis. The majority of patients with asbestos-related pleuropulmonary disease are asymptomatic. Patients beyond the early stage of interstitial fibrosis will often experience shortness of breath, a restrictive pattern of pulmonary function test. These patients are also at risk of developing asbestos-associated neoplasia, particularly bronchogenic carcinoma and pleural mesothelioma. The radiographic finding of asbestosis occur in two forms, either small or large opacities. The small opacity may be reticular, nodular, or combination of two, which is divided into three stages. The earliest finding is a fine reticulation, mostly in the lower lung zones, which manifests of early interstitial pneumonitis and fibrosis. With time, small irregular opacities become more prominent, creating a core transparent reticular pattern. The later stage, reticular opacity may extend into the mid and upper zone. with progressive obscuration of the cardiac and diaphragmatic margin and progressive diminution of the lung volume. The second type, large opacity, those measuring greater than 1 cm in diameter, are invariably associated with widespread interstitial fibrosis and pleural plaques. These large opacities shows lower zone predominance and may be well defined or ill-defined and multiple. The small one upper and middle, the large one lower zone. The second one is silicosis. Silica now is abundant mineral composed of regular arranged molecules of silicon dioxide. Two distinct histopathologic reactions to inhaled silica produced, which is either silicotic nodule or silicoproteinosis. First, silicotic nodule measure from 1 to 10 millimeter in diameter and are made up of dense concentric lamella of collagen. They are typically most numerous in the upper and parahilar region. Calcification or ossification of the nodule is common. Coalescence of these nodules produce areas of progressive massive fibrosis, which may occupy an entire lobe, with areas of emphysema often present adjacent to this mass. Exposure of 10 to 20 years is usually required for radiographic change of fibrotic silicosis to develop.
The PMF masses usually starts more peripheral.
Yes.
And then it, like due to the fibrosis,
Yes.
it migrates centrally.
Yes.
So the areas away, outside of the PMF will become emphysema. So the emphysema is after the migration.
Migration, yes.
Happens, okay? After the maturation of the
Yes,
PMF.
it's a sequelae.
Yeah, exactly.
Hilar lymph node enlargement may be seen at any stage, and these hilar nodes often demonstrate peripheral eggshell calcification. The second type, silicoproteinosis, image. This is the silicosis in the X-ray shows multiple reticular shadow, that's arrowhead.
So you can see there are multiple nodules.
Yes.
In the lung, in the X-ray, especially in the mid and upper, more severely affected lung
Yes.
zones bilaterally. And
Bilaterally.
you can notice the trachea is getting to the right side, indicating
Yes,
some
with the fibrotic and
traction
traction.
changes.
Yes,
And in the
The
CT
pull.
scan, you can see there is a big mass-like lesion.
big mass.
Otherwise, we will consider it a tumor. Okay, but in this case, it is not a tumor. It is just a
Fibrotic, yes.
PMF, progressive
Yes.
massive fibrosis, but large mass-like lesion. Usually it is bilateral. Here it's more on the right side, but usually it happens bilaterally.
Now, there is other multiple
There are
nodules,
nodules. These
peripherally.
nodules on the left side will mature into PMF later.
EMF later. The silicoproteinosis usually occur in individuals exposed to very high concentration of silica. It's characterized by filling of the alveolar space with lipoproteinaceous material. The acute stage presents radiographically with the diffuse airspace disease, and it's indistinguishable in appearance from the idiopathic alveolar proteinosis. Patients with acute silicoproteinosis and silicone nodules with fibrosis have increased susceptibility to infection like TB and nocardia, which may produce mass-like consolidation and sometimes chest wall involvement seen.
And keep in mind, about I think 10 to 25% of patients with silicosis, they have TB. Okay, it's called silico-TB. Okay, so you'll see features of both TB and silicosis superimposed on each other. And this is a very common board-worm case. It happens every other year. Silico-TB, silico-TB. See features of both. Keep that in mind. It's you cannot differentiate it from alveolar proteinosis, the usual alveolar proteinosis. Okay? I don't. If treated, I don't think it will progress because it's acute presentation with massive dose of silica. When someone
it's not interstitial, it's alveolar.
Exactly. Constant exposure will result into fibrosis if the exposure is not removed.
Co-workers pneumonia, pneumoconiosis, the inhalation of the large amount of carbon-containing inorganic material may lead to significant pulmonary disease. This because mostly occur in occupationally in coal mining. That's called coal workers pneumoconiosis. It has two characteristic pathological findings, either coal dust macule or then progress to PMF, a round or satellite nodule ranging in size from 1 to 5 millimeter. They are composed of pigmented laden macrophage with minimal or absent collagen formation. They are found within the interstitium adjacent to respiratory bronchioles and are scattered throughout the lung with a predilection for the apices. PMF defined as nodular or mass-like lesion exceeding 2 to 3 cm in diameter and are composed of irregular fibrosis and pigment, and most commonly in posterior segment of the upper lobe or superior segment of the lower lobes.
So keep in mind, PMF does not always mean silicosis.
Yes.
PMF can happen in a variety of conditions.
Yes.
The most famous one is silicosis, but it
Yes.
can happen in other conditions.
There are other causes. Now we go.
Differential diagnosis.
Yes, cause PMF. Now we go. Central cavitation is a common and most often a result of infarction from the obliteration of the pulmonary vessel by fibrotic masses. Occasionally, superinfection of the mass by TB or fungus accounts for central necrosis and cavitation. Kaplan syndrome or rheumatoid pneumoconiosis. This seen in coal workers with rheumatoid arthritis. It's seen nodular opacity ranging from 0.5 to 5 cm in diameter, which develop rapidly. The nodules are more sharply defined and seen more peripherally than the mass of PMF. These lesions are not specific for CWP and may be seen in patients with silicosis or asbestosis. The next is hypersensitivity pneumonitis. Hypersensitivity pneumonitis or extrinsic allergic alveolitis, it's an immunologic pulmonary disorder associated with inhalation of antigenic organic dust. These dust may be small particle size to penetrate into alveolar space and cause host inflammatory response. A wide variety of etiologic agents have been implicated, including many thermophilic bacteria, true fungi, and various animal proteins. Some of the most common disease entities include farmer's lung, humidifier's lung, and bird fancy's lung.
What do you think is the most common type here in our region?
Bird fanciers.
We see it all the time, bird fancy.
In the rural areas.
Because a lot of people have birds in their house, especially some of them inside the house.
Yes. Two forms of disease are distinguished by their clinical presentation. The acute disease develops 4 to 6 hours following the exposure of the antigen. The typical symptoms include cough, dyspnea, and fever. The chronic disease is often insidious and commonly results in interstitial pulmonary fibrosis. Patients with chronic disease often have malaise, chronic cough, and progressive dyspnea. The chest radiograph may be normal in early stage and in acute stage. Within hours, fine nodular or ground glass opacities develop, most often in the lower lobes. Progressive airspace opacification may simulate pulmonary edema. With hours to days, the opacities are resolved and the chest radiograph becomes normal. With continued or repeated exposure, the chest radiograph will remain abnormal between acute episodes. The chronic changes appear as diffuse coarse reticulation of or reticulonodular opacities in the mid-lung and upper zone.
So again, starts low, ends up.
Yes. And maybe cause loss of lung volume because of repeated chronic infection. The subacute phase is characterized by patchy areas of ground glass opacity and poorly defined fuzzy centrilobular nodule. This finding may be superimposed on one another and both show a predilection in the mid and lower zone. In chronic phase, the disease findings are those fibrosis, interlobular and intralobular interstitial thickening, honeycombing, and traction bronchiectasis. This is the chronic stage. Distribution of the disease is varied, but sometimes there is a relative sparing of the costophrenic angles. This may help in distinguishing hypersensitivity pneumonitis from UIP, usual interstitial pneumonia.
Usual interstitial pneumonia has an apico-basal grade.
Yes.
It's more in the base than in the apex. And it usually involves the costophrenic angles.
Yes.
While in the hypersensitivity pneumonitis, the same thing, but usually spares the costophrenic angle. First. Second, the most common phase that we see is acute or chronic or subacute that we usually see in our practice.
Acute is not seen radiographically. So, that's why not coming to us.
Most commonly we see subacute.
Yes.
These fuzzy nodules, centrilobular, some faint ground glass opacities. These are the usually we see this phase rather than the fibrotic. The fibrotic phase will not be able to distinguish it. Is it due to hypersensitivity? Is it due to UIP or other causes? The one that we can suggest hypersensitivity pneumonitis is
subacute one.
Subacute stage. Like this.
This is
a very characteristic picture. You can see this geographical pattern. It's look like a little bit like crazy paving appearance. There are some faint ground glass opacities, and if you look carefully, you can see faint centrilobular nodules. For example, like this one. It's due to the projector. It's not very obvious in the book. It's better. These ill-defined nodules are. You should suggest if you ask the patient about history of exposure to like birds or things like that, and he says yes, this is typical subacute hypersensitivity pneumonitis.
Now we are going to granulomatous disease. The most common is sarcoidosis. Sarcoidosis is a multisystemic granulomatous disease of unknown etiology, characterized by non-caseating granulomatous that may progress to fibrosis. The disease is seen more commonly in blacks and rare in Asians. Most patients are 20 to 40 years of age at the time of diagnosis. However, because many patients are asymptomatic, many cases are never identified. The earliest change involved the pulmonary interstitium with the development of non-specific lymphocytic and histiocytic infiltrate. this progress to formation of microscopic granuloma. In contrast to tuberculous granuloma, which is non-caseating. The clinical presentation of sarcoidosis may dominate by either pulmonary manifestation, extrapulmonary manifestation, or maybe asymptomatic, as we said. Lymph node enlargement may be found in 80% of the patients with sarcoidosis. And the classic appearance is combination of right paratracheal and bilateral symmetrical hilar lymph node enlargement. The symmetric enlargement is a key feature that allows distinction from malignancy and TB. Conditions that usually produce unilateral or asymmetric lymph node enlargement. This is also seen lobulated because it's discrete and seen lobulated. Left paratracheal lymph node enlargement is common, but in chest X-ray we couldn't see clearly. That's why determined by CT.
Keep in mind, symmetric, bilateral, high lymphadenopathy, it means
sarcoidosis until
proven otherwise. Shuf, bilateral, symmetrical, hilar lymph node, this is sarcoidosis. Very unlikely to be others, like TB or lymphoma or
like this case, bilateral hilar
exactly. Symmetrical, bilateral, hilar lymphadenopathy.
With the right paratracheal.
Okay.
Sometimes, in 5%, unilateral hilar lymph node enlargement is seen, but it's unusual.
It's 5%.
Yes. The enlarged lymph node regress within 2 years in 75% of affected patients. A small percentage of patients will have persistent lymph node enlargement for years. The development of parenchymal opacities concomitant with the resolution of the lymph node, which is a helpful feature to differentiate lymphoma from the sarcoidosis. In lymphoma, enlarged lymph node do not regress when parenchymal abnormalities develop. Calcification in this condition may be seen in 20% of the patient, and it's typically eggshell calcification.
So, in sarcoidosis, when the lymph nodes resolve, parenchymal abnormalities start to appear.
Yes.
Not together.
Yes.
Start transmission from stage 1 to stage 2. Stage 1 lymph nodes, stage 2 both, then parenchymal. Stage 2 usually short. While in lymphoma, you have lymph nodes and parenchymal opacity together. Continuously.
Yes. Lung disease involved can be seen radiographically in only 40 to 50% of patients with sarcoidosis, despite the nearly 90% yield from the transbronchial biopsy of the lung and diagnosed. The most common parenchymal abnormality is bilateral symmetrical reticulonodular opacity, show a predilection for the mid and upper zone. The appearance of reticulonodular opacity never precedes the enlargement of hilar and mediastinal lymph nodes. This is different case of sarcoidosis with the reticulonodular opacities. In the chest X-ray, see multiple reticular shadows. In the coronal coronal chest CT shows multiple peripheral nodular opacities. Some admixed reticulation may be seen. This is the red arrowheads in upper and mid lung zone. Nodal or mass-like sarcoidosis develop in a manner similar to alveolar disease. These mass can be quite large and typically have a sharp margin. Air bronchogram are often demonstrated on CT and thin section CT. Pulmonary fibrosis develop in 20% of patients with long-standing parenchymal involvement. On CT, the mass contain air bronchogram with traction bronchiectasis. Pleural changes. Pleural thickening or effusion occurs in approximately 7% of patients. It's not common. Patient with sarcoidosis. This results in granulomatous inflammation of the visceral and parietal pleura. Aggregation of nodules along the pleural surface can cause pleural pseudoplex. There are other findings like endobronchial granulomas can result in fibrosis of the bronchial wall and bronchial stenosis. Pulmonary arterial hypertension is an uncommon finding and usually secondary to long-standing pulmonary fibrosis. This is CT appearance of pulmonary sarcoidosis in 3 different patients. First, the commonest one, typical perihilar nodules, perilymphatic nodules. The second one is not common, it's a miliary nodule. The third one is a mass-like opacities.
You can see the mass-like opacities,
Multiple.
Like tumors,
Yes.
You should see some air bronchogram inside. So the last 2 are not common.
Uncommon.
But the first one is the common. It's very common
Yes.
to find these features in pulmonary sarcoidosis.
It's divided into 5 stages. The stage 1 disease is associated with a 75% rate of resolution, whereas only 30% of patients with the stage 2 and 10% of patients with the stage 3 resolve. This is the radiographic finding. Stage 0, normal chest. Stage 1, bilateral hilar lymph node enlargement. Stage 2, bilateral lymph node enlargement and parenchymal disease. Stage 3, parenchymal disease only, and 4 progress to fibrosis. This is stage 4. We see multiple fibrosis and traction and distortion of the hilar and mediastinum. With coronary format showed perihilar fibrosis. This the red arrowhead with the traction bronchiectasis. When it start to regress, not regress completely.
They occur together in a brief period of time. Then the lymph node will go away and the parenchymal changes will stay. يعني هو مو ينام بالليل عنده lymph node بعد الصبح عنده parenchymal changes. Gradual transmission from stage 1, stage 2 to stage 3.
When you have stage 3, you have passed one after.
Sure, definitely. You never see lung changes if there was not previous lymph nodes. Exactly. You must have previous lymph nodes.
Langerhans cell histiocytosis. Pathologic features are different in age at the time of diagnosis, mode of presentation, and specific organs involved. Previously called eosinophilic granuloma, presented with predominant involvement of the lung and bones. The disease most commonly affects the young adult and has no sex predilection. Small peribronchial nodules may coalesce to form large nodules, which may cavitate or may extend to infiltrate the alveolar septa and induce an interstitial inflammatory reaction. The nodules may resolve completely, but in most patients, the central portion of the nodules undergo fibrosis. In late stage, the characteristic findings include fibrosis, development of the small, uniform, thin-walled cysts. Large peripheral cysts or bullae may develop in the apical region. The earliest findings are small to medium nodule opacity. They tend to have upper and mid lung zone distribution. In some cases, the nodule coalesces to form large nodules or mass, as we said. The latest stage of the disease is characterized by coarse reticular pattern of the intermixed thin-walled cyst. Hilar or mediastinal lymph node enlargement is distinctly uncommon in this case conditions. Pneumothorax from the rupture of the cyst or bulli is the presenting finding or developed during the course of the disease in up to 25% of patients. Pleural effusion in the absence of pneumothorax is rare. Extrapulmonary manifestation include well-defined lytic, rib or vertebral lesions. Thin section CT in patient with a relative short duration of symptoms, less than 6 months, shows well-defined interstitial nodule of varying size, sometimes with cavitation and cyst formation in the upper lungs. More long-standing disease characterized by large cyst and honeycombing. Nodules and thick-walled cysts can transform into thin-walled cysts. This is Langerhans cell histiocytosis on thin section CT. Shows multiple cysts with thin but well-defined. They are more extensive with little normal intervening parenchyma in this.
And keep in mind the main differential diagnosis in such cases, if the patient is a female,
Yes.
you put lymphangiomyomatosis.
Yes.
It's very similar appearance. If female,
But
male,
yes,
never.
yes. It's uniform. Yeah.
This is not uniform. Well, uniform. They say it's not uniform.
But in written in book, it's more uniform in size. Yes.
Come on.
Yes.
Lymphangiomyomatosis has no relation to this one. Lymphangiomyomatosis, it's the disease of smooth muscle proliferation, exclusively in females, and with patients with tuberous sclerosis. Okay, while example granuloma is a idiopathic disease, so it's more likely to be related with small.
The other granulomatous disease is Wegener granulomatosis, which is a systemic autoimmune disorder characterized by necrotizing granulomatous vasculitis involving in the upper and lower respiratory tracts and kidneys. The characteristic lesions in the lung are discrete nodule or masses of granulomatous inflammation with a central necrosis and cavitation. Most patients with Wegener granulomatous are middle-aged. Respiratory tract is affected in 100% of patients. The differential diagnosis of Wegener granuloma is Goodpasture syndrome, which is idiopathic pulmonary hemorrhage. Renal involvement follows involvement of the respiratory tract and is seen almost in 90% of patients, which is even not diagnosed and by renal biopsy, which is non-specific granulomatous disease. Wegener granulomatous, it may affect the lung, trachea, bronchi, upper airway, and pleura. The characteristic radiographic finding of lung involvement in Wegener granulomatous are multiple, sharply marginated nodule or may progress to mass, which is either solitary but may be seen as multiple. Some disappear and other comes. The cavitary lesions are irregular, thick-walled cavities seen in 50% of patients during the course of disease. Localized or diffuse areas of airspace opacification can represent hemorrhage or pneumonia. Tracheal or bronchial lesions may present and are usually best appreciated on CT. They may appear as calcified mucosal or submucosal deposits, which produce irregular narrowing of the airway lumen. Pleural effusion from the pleural involvement is not uncommon. Pneumothorax may result from rupture of a cavity into the pleural space. Lymph node enlargement is not seen in this condition because it's a vasculitis. This is a condition of Wegener's granulomatosis. We see a well-defined mass at the periphery of the upper lobe.
You can see some areas of
And you can see, yes.
calcifications, bronchogram, surrounding pneumonia-like
Yes.
features. And
But the
when
characteristic finding is a nodule.
yeah, a mass like.
Yes,
Like the
yes.
one on the right, on the left side.
Yes.
However, when you have a suspicion of
Yeah.
Wegener's, you image the sinuses, not the lungs.
Yes. Sinus.
It's most likely you find an abnormal sinuses.
Yes,
trigeminal
sinusitis.
sinuses. Okay?
Yes.
You don't image the kidney, you don't image the lung. You start with the sinuses and go from there.
The definite diagnosis is by biopsy of the lung, not the kidney. The eosinophilic lung disease. This term refers to heterogeneous group of allergic disease characterized by excess eosinophilic in the lung and occasionally blood. Excess eosinophils. This is either idiopathic or with a known etiology like drugs like antibiotic, penicillin, nitrofurantoin, or autoimmune disease like Wegener granulomatosis, sarcoidosis, rheumatologic lung disease, polyarteritis nodosa, Church-Strauss syndrome. First, simple pulmonary eosinophilia, also known as Loeffler syndrome, is a transient pulmonary process characterized pathologically by pulmonary infiltration with an eosinophilic exudate. Most patients have history of allergy, most commonly asthma. The radiological finding is peripheral, homogeneous, ill-defined areas of airspace opacity that may parallel the chest wall. The opacities in Loeffler syndrome have been described as fleeting because there is a tendency for rapid clearing of one area with a new involvement of other areas. The clinically dry cough, dyspnea, and peripheral blood eosinophilia are common, but are not invariably present. The diagnosis is based on the combination of pulmonary symptom, blood eosinophilia, and radiographic findings. And most common are self-limiting within 4 weeks. The chronic eosinophilic pneumonia, patients with symptoms are a radiographic abnormality that lasts longer than 1 month. The clinical and radiographic features are similar to those on Loeffler syndrome, although there is a distinct predilection for women. It responds dramatically to steroid, which improve within 4 to 7 days, but relapse is common
If the drug is stopped.
if the drugs is stopped.
So you can see here, peripheral, parallel to the chest
Wall.
parallel to the pleural, nodular opacities,
Yes.
indicating
Ground glass, yes.
pneumonia.
Yes. The more severe is hypereosinophilic syndrome. It's a systemic disorder with a mild predominance that is characterized by multiple organ damage from eosinophilic infiltration of the tissue. Blood eosinophilia is prolonged and marked in this condition. Pulmonary parenchymal infiltration with eosinophil may produce interstitial or airspace opacities. Eosinophilic lung disease of identified etiology. We said that there is many causes. Eosinophilic lung disease with autoimmune, as in the picture, like Wegener granulomatosis, sarcoidosis, can be seen. And also drug-induced lung disease. There are many patterns of drug-induced lung disease. This is either diffuse alveolar damage, usual interstitial pneumonia, non-specific interstitial pneumonitis, eosinophilic pneumonia, bronchiolitis obliterans with organizing pneumonia, hemorrhage, and there are many drugs can cause this conditions.
So you can see that biliomycin is the only one that has a poor prognosis.
Yes.
Keep this in mind. Carmostine, they use it for acetylene form like that. It's like a little more.
This is other drug, rituximab-induced diffuse lung disease.
You can see interstitial fibrosis, traction
Yes.
bronchiectasis, some of the emphysematic changes bilaterally. It's due to diffuse lung injury
Yes.
from the treatment.
Pulmonary hemorrhage also can be caused by drugs.
If something like anticoagulants, they're
Yes.
bleeding into the lung,
Yes.
then will lead to lung damage. You can see areas of space opacification, of ground glass opacification. If the bleeding is controlled, it may resolve completely. Or there is an infarction for any reason to leave a fibrotic scar.
Yes.
Okay?
And it's diagnosed after the clinical suspicion by lavage,
They do lavage,
Yeah.
it returned bloody,
bloody,
then there's blood.
and microscopically there is alveolar macrophage contain hemosiderin. Pulmonary alveolar proteinosis is a rare disease which the lipoproteinaceous material surfactant deposit in the abnormal amount within airspace of the lung. Its predilection for 20 to 40 years old men mostly, and has been seen in patients with acute silicoproteinosis and immunocompromised patients with lymphoma, leukemia or AIDS patients. Patients are often asymptomatic, although some complain of progressive dyspnea and non-productive cough. The absence of orthopnea is important clinical feature distinguishing proteinosis from the pulmonary edema secondary to congestive heart failure.
Pulmonary edema usually
In
are
chest
very
X-ray.
similar to alveolar proteinosis.
In chest X-ray.
Exactly.
Yes.
Clinically, it looks the same, except in one difference. If the patient has a heart failure, he will suffocate if he lies down.
Yes.
While in
Orthopnea.
alveolar proteinosis, he will not.
Yes. There is no difference.
No orthopnea.
Yes. The radiological finding, bilateral symmetric perihilar space opacification, which is indistinguishable from pulmonary edema, and the characteristic radiological finding is crazy puffing. Other conditions can produce this pattern, like pulmonary edema, atypical pneumonia, and pulmonary hemorrhage. Rarely, bronchoalveolar cell carcinoma can produce crazy puffing. This is the typical finding of crazy puffing in CT scan.
You can see the appearance of very characteristic interlobular septal thickening
Yes.
with diffuse faint ground glass opacities. Usually they are bilateral and symmetrical.
Yes.
No orthopnea. You should keep in mind possibility of
Alveolar proteinosis. Alveolar microlithias is a rare disorder characterized by deposition of a minute calculi within the alveolar space. While alveolar microlithias can affect individuals of any age without sex predilection, there is a very high incidence of in the sibling.
siblings.
Yes, aqarib. The underlying abnormality responsible for the formation of calculi, known as calcospheroids, is unknown. There are small calculi measuring less than 1 millimeter.
Tiny calcium phosphide diffuse all over the lung.
Yes.
Okay.
The diagnosis made by by history of alveolar microlithias in sibling, combination with typical radiographic finding, and there is no effective treatment. Lastly, diffuse pulmonary ossification, which is also uncommon, but characterized by formation of bone within the lung parenchyma. The nodular form of this is seen in mitral stenosis, whereas more irregular ossification is seen in chronic inflammatory conditions such as amyloidosis and usual interstitial pneumonia. Secondary hyperparathyroidism and amiodarone can cause diffuse pulmonary ossification because amiodarone precipitate in lung
Amidon does not cause pulmonary ossification. It
yes
causes interstitial disease,
disease
with a high density.
high density
Amidon nafsه
yes
is a high density drug.
yes
يعني you do the image without contrast, you see the image like there is contrast.
yes
Okay?
yes thank you.
Thank you very much. It's a good presentation, nice. Not an easy subject, however, it's very important. A lot of important exam cases occurs in this